Alzheimer's Meditech, and I would like to also acknowledge my colleague, Dr. Sheetal Brar, who has helped me in this research. So we will look at going to the next step where you can refine the SMILE procedure and improve patient satisfaction and get better visual outcomes. So first is, of course, we were talking about this before, but energy optimization is very important, and energy level should be optimized to prevent OBL and obtain a uniform density of the bubble layer. And for most Visomax lasers, the fluence levels of anywhere between 22 to 32, corresponding to an energy of 110 to 160 nanojoules may be required. And this varies from machine to machine and the environment. So every machine is individualized, and you will have to kind of obtain your optimal energy levels to get a very nice bubble layer. And so far, no sign was described to signify the endpoint where you get a optimal energy. And so we were looking at this, and then we brought out an article which was published in the GRS in 2019, and what we described the gas bubble escape sign. It's an intraoperative sign to predict the immediate visual quality after SMILE and the quality of the bubble layer. So let us look at this video, and you can see that the bubble layer is very uniform here, and there is hardly any OBL. And as soon as you open the incision, you can see that the cornea clarity improves and it becomes transparent. And then, of course, you can dissect the layers. And I want you to look at the ease of dissection. I always use a forceps to stabilize the eye and provide countertraction. But you can see that it's so easy to dissect. There's no OBL and there's hardly any resistance. And if you have a very nice bubble layer, then the post-op visual recovery also is quite good. So this is the escape of femtobubbles as the incision is accessed. And there's an immediate generalized clarity in the appearance of the interface. Let's look at another video. You can see that the bubble layer is there. As soon as you open it, you can see that the bubbles escape and then the clarity improves. So this is what we call the gas bubble escape sign. And the reason why this, okay. So what we noticed is we also looked at the OSI, that's the objective scatter index with the HD analyzer on day 1 and day 15 for eyes which had the gas bubble sign and the eyes which did not have a gas bubble sign. And we saw that there was a significant difference. You can see that the OSI day 1 was much better in the eyes having the gas bubble sign as compared to the no gas bubble sign. Of course, at 15 days, also there was a difference, but it was not statistically significant. So the clinical significance is when you have a uniform bubble layer without any opaque bubbles. Opaque bubbles is basically a concentration of the bubbles, and the bubbles get entrapped there. So when you have patches of OBL, that does not allow for the bubbles to escape once you open the incision. Also, if there are any black spots, they also block the escape of bubbles. So when you have a uniform bubble pattern, then as soon as you access the incision, then the bubbles escape. And this is one of the signs which show you that your energy is optimized. So the limitation is that we were able to observe this only in approximately 65 to 70% of eyes. And even though your energy is optimized, you may not see it in all eyes. It's probably because of corneal biomechanics, which vary from eye to eye. But generally, this can be a useful indicator of the energy optimization in SMILE, and you can also use it to predict your immediate post-op visual quality. And it may guide the surgeons for fine-tuning the laser energy. So once you have optimized your laser energy, again, Dr. Tithial spoke on techniques, and this is a technique which we described, lenticuloschisis, or a no dissection technique. And this was published in 2017 in GRS. And let me show you the video. This is Actually, this should be attempted only once you have an optimal energy level. And then if you have OBL or if you have black spots, then it's not ideal to use this technique. You should be also fairly skilled. So this is a technique where you directly enter the interface with your forceps, open the jaws, grasp the lenticule on either side, push it down. And you can see it was so transparent, the cornea, because of the gas bubble escape sign. And then you can just peel it off. And this is all it takes, just a few seconds. And you don't have to do an interface wash. And what we saw post-op clinically, if you see the two images, we compared the dissection technique where we used a spatula and the no dissection technique. In the dissection technique, you see that the interface is rougher and you have a prominent cap edge. That's because you go to the periphery and you're pushing with your spatula, and that stresses the bowments and it expands the bowments, because the bowments is a plastic layer. And because of the expansion, you get bowments wrinkles, and that can affect the quality of vision on day one and the scatter. And that's why we looked at the objective scatter index. And in the no dissection technique, you can see the retroillumination photographs. The interface is much clearer and uniform. You don't have any rough spaces. And if you see, there is no prominence. You can hardly make out the cap edge because you're not pushed and you're not gone to the edge. You can see you can't make out the cap edge. So this is probably the reason why the first day quality of vision is better. The other very important research that we just did, and of course this is under review for publication, is differential spot spacing parameters. Now, conventional practice is to use the same spot distance for both the cap and the lenticule. Oops, sorry, I just jumped. But then if you look at the cornea, you can see that the structure of the cornea is not uniform. You have the superficial layer where you have thinner collagen and which is more compact, and the deeper layers where you have the thicker collagen and then wider spacing and gaps. It's like Swiss cheese. Okay, so you have the thicker and wider collagen fibers deeper and thinner. So it makes the cornea is not uniform. So it makes sense to have a differential energy for the superficial and the deep layers. But you can't do that because if you have differential energies, then the laser has to stop and recalibrate, and it takes more time. So what we thought is we'll have differential spot spacing. So the energy per square millimeter will vary between the superficial and deep. So we used a spot distance of 4.5 for the superficial layer and a spot distance of 4.2 for the deeper layer. So you had closer spots. So the energy per square millimeter increases. So you had more energy in the deeper spots because the fibers are thicker. So you need a little more energy to cut the thicker fibers. Oops, jumping, sorry. So this was a contralateral eye study, 100 eyes, 50 patients with spherical equivalent more than 5 diopters eligible for SMILE. In the conventional technique, we used an energy cut index of 30, spot distance for 4.5 for both the cap and lenticule cut. And in the differential spot group, we use an energy cut index of 28, and the spot distance was 4.5 microns for the cap cut and 4.2 for the lenticule cut. Now we scored, the surgeon scored the ease of post-op posterior plane dissection, and from 1 to 5, 1 being very difficult and 5 effortless. And in the standard spot, it was 2.4. In the differential spot, it was 3.8. So there was a significant difference in the ease of dissection of the posterior plane. We also looked at the uncorrected distance visual acuity day 1, 2 weeks, and 3 months, and we found that with the differential spot, the uncorrected vision was much better. This is a contralateral eye, so the corneal biomechanics is equal. At 2 weeks, it was not that significant. Again, at 3 weeks, it was significant. We also compared the OSI, the scatter at day 1, 2 weeks, and 3 weeks, and we found that the OSIs were much better with the much lower with the differential spot than the standard settings. at day 1, day 2, and week 2 and 3 months. 3 months, of course, it was not statistically significant. That's probably because the interface had healed. So as a routine now, we are using this. We keep 4.5 for the anterior and plane and 4.2 for the posterior plane. The other study which we did was small versus medium cone for smile, because what the company recommends is that you look at the white to white and then select the cone, the horizontal white to white, and if it's less than 12 millimeter, you use a small cone. If it's more than 12 millimeter, you use a medium cone. But when we looked at the bubble pattern with a small cone, we used to get a uniform bubble pattern for the same energy. With the medium cone, what we found that we used to get more OBL in the mid periphery. You can see very clearly that the OBL is much more in the mid peripheral area, and the dissection was a little more difficult, and the visual recovery with medium cones also. Day 1, the vision was not as good. So we did this clinical study. This was to compare the visual outcome and quality of vision using a small versus medium cone in patients with large corneal diameter, more than 12 millimeter, undergoing relaxed smile. This was a randomized contralateral eye study, 60 eyes of 30 patients, and relaxed smile was performed using standard technique. Post-op regimen was similar. Follow-up was day 1, 2 weeks, and 3 months. This was the uncorrected visual acuity, and you can see in day 1, the group with the S-cone had a significantly better visual acuity, uncorrected visual acuity, and even at 2 weeks it was better, and 3 months also it was better, but it was significant on day 1. We also looked at the OSI, which is the objective scatter index, which gives us the quality of vision and the quality of the interface. And we saw that with the small cones, day 1 and 2 weeks, it was significantly better than the medium cone group. At 3 months, again, it was better, but not statistically significant. So if you look at LASIK and corneal diameters and how you select the flap diameter, there are various tips and pearls which have been published. But however, SMILE is different from LASIK. SMILE, the cap diameter is fixed, and maximum you go to 8 millimeters, because the white to white is not as critical. Maximum you may use an optical zone of 7 or 7.5 millimeter, and you can use a cap diameter of 8 millimeter. Usually you don't go more than 7 millimeter because it consumes a lot of tissue, and it is not required because pupils are not bigger than 7 or 7.5 millimeters. So using a small cone for all cases of SMILE is preferable. Again, the small cone ensures better fit because the radius of curvature of both the small and medium cone is the same. But what happens is, as your diameter increases, the sagittal height increases. And when the sagittal height increases, it becomes relatively steeper, like a contact lens. The same radius of curvature, if you increase the diameter of the contact lens, there's nothing but a contact lens, then you get a steeper fit. So when you, with a small cone, you have a flatter fit, it fits very well. With a medium cone, you have a steeper fit. So you have to compress the cornea, you have to do a hard dock. You can't do like an 80% dock. And when you do a hard dock, you have more compression of the mid-peripheral tissue. And that's why you see that OBL, because of the compression. So that is, again, this is under review for publication. The other work which we did was cyclotorsion compensation, where initially, of course, with SMILE, there is no tracker for cyclotorsion. And we all know that cyclotorsion can occur because of various reasons, just static cyclotortion when the patient lies down and you have done all your measurements of the cylinder and the axis with the patient sitting up, and when the patient lies down, there can be some amount of cyclotorsion. Now, it is very important to compensate for this. Of course, some studies have shown that it doesn't make a difference. But again, if the cylinder is very small, and what we found is that in 85% of patients, it doesn't make a difference. In 15%, there is significant cyclotorsion, and these patients have to be compensated. Otherwise, you can have loss of BCVA. Now, how we do it is pre-op 180-degree marking is done using the either the Akoshi or the Ganesh bubble marker. You can use an infrared transmitting dye, which is the viscose surgical skin marker, and patient is positioned under the Viscomax, instructed to look at the green flashing light. And then the docking is done. I'll show you the video. This is the publication 2017 in GRS, and then following this publication, in fact, Zeiss has given a recommendation that manual compensation be done in cylinders more than 1.5. We found that in higher cylinders more than 1.5, or if your sphere is less and then you have more of a cylinder and then more than 1.5, then there is a chance, there's like a 15% chance that you can have significant cyclotorsion. Of course, if your study group is small, just about 20, 30 eyes, then most of them may be within that 85%, you find it is not significant. But it is common sense, whether for any astigmatism, whether it is for LASIK, PRK, SMILE, toric ICL, toric IUL, you have to be on axis. Otherwise, it can undercorrect the cylinder and you can have induced abrasions. Even for a contact lens, you do a prism ballasting for a toric. A contact lens is nothing but a lenticule which is there on the eye, and you do a toric prism ballasting. And even when the patient blinks, when there is a slight movement, the quality of vision reduces. And patients wearing toric contact lenses know this. When they blink, the contact lens rotates a little, then the quality of vision reduces, then it settles down. So it's very important to, and all the new machines coming out now, the SMILE machines, will have cyclotorsion compensation. So here the eye is docked, suction is applied, any cyclotorsion is measured. You can either use the reticule as a reference, or you can use the screen as a reference, and then the cone is rotated to align the two. And if the difference is high, more than 10 degrees, sometimes we see up to 15 degrees, then it's better to redock the eye, because if you move the cone too much, there is a risk of suction loss. So this is how you do it. After you dock and then you put on the section, you hold the cone, and then you can see here, there's almost a 10-degree cyclotorsion. We rotate it before firing the laser, because if you don't rotate it, then the cylinder is off. And we also have a study with the control group. Gitansha was saying about the control group, we did a retrospective study, because knowing well that cyclotorsion kind of improves results, it's unethical to do contralateral eye or two groups. So we just did a retrospective analysis of when we are not doing cyclotorsion, and then when we started doing cyclotortion. And what we found is that gain in lines is much better in the cyclotorsion compensation group. It is significant. So now I have devised a 3-point epithelial marker, because when you mark with ink, what happens is the ink can spread. And if you don't use an infrared transmitting ink, then it can block the laser. And if the ink spreads, then that itself can give 3-4 degrees difference in marking. You need a sharp line. So I have a 3-point epithelial marker. This is an inkless method. It gives you linear marks at 3, 6 o'clock, and 9 o'clock, 3 reference marks. You get long marks visible after you dock, and the epithelium is indented slightly. It does not lead to discomfort post-op, and we see better results now. So those were few of our few of the research that we did, and publications which help you to get to the next level in SMILE. Thank you very much for your attention.
Thank you very much, Shiri.